How's it going, modern manual therapy viewers? Dr. E here, back with another MMT Q&A. This time it's from Doug Murray, a fellow faculty member of Next Gen PT Institute. After taking my seminar on modern manual therapy, upper quarter and lower quarter, the eclectic approach to assessment and treatment, he writes, just a quick question on symptoms peripheralization on cervical loading patterns of the neck. So he has a 33-year-old female patient with right shoulder and neck pain that started while doing a push-up. It locked up her neck for a few days and her right scapula dropped about a full inch. Neuroscan was normal. In a few days it improved and range of motion was normal and shoulder height was restored and neurodynamic is now negative. She now has moderate intermittent pain and meets the upper quarter clinical practice patterns of reduced retraction and side bending toward the painful side or the involved side, which in this case is the right. When she loads in a retraction, her shoulder pain worsens and continues to worsen as she does them. The pain recovers, but this reproduction is consistent. So in other words, it's a yellow light. So symptoms increase when loaded into retraction and side bending, but they don't stay worse. They don't remain worse after the repeated loading strategy is done. When he has retraction and side bending, the pain worsens and it peripheralizes down to her elbow. This is not improved. Again, it's still a yellow light. She is limited in right side bending or retraction. Retraction is full, but it's painful. All other motions are normal and her shoulder exam is normal. His question, this is a great question as well when it comes to the red light, yellow light, and green light in terms of the stoplight rule on whether or not you should proceed with a particular treatment, repeated loading strategy is, even though it's a yellow light, how much peripheralization of symptoms are you comfortable with before you say, okay, continue with it? In general, what are you thinking when your patient's symptoms peripheralize with cervical retractions? That is a great question, and what I say during my courses is that even though it's a yellow light, if you were to go by the book, you would technically repeatedly load it and load it and load it. And even with peripheralization, as long as it goes away, they can kind of walk it off. And one of my favorite things to do is if you irritate something, and I always explain to the patient like, oh, you know, no damage is done, no permanent harm is done. If your symptoms increase or they otherwise peripheralize, just try to walk it off. And often when they go walk up and down the clinic or the gym for a minute or two, if it goes back down to baseline or sometimes even better, then you know it's not that irritable. However, in my experience, when symptoms peripheralize, even with the yellow light, meaning they can walk it off, I find that they're not as much of a rapid responder as you would like. So I surmise that it's possibly due to the fact that maybe they don't load to end range or they don't load repeatedly enough to actually centralize to complaints, and maybe they don't do it with enough frequency for the nervous system to be convinced that this is a safe movement when you're trying to restore something like cervical retraction and side bending. Those patients tend to be a bit more irritable, and the nervous system tends to, even though it peripheralizes, even if it doesn't remain peripheral, I would say that you probably need to choose a different strategy. Now I'm going to throw a clinical pearl into this. Usually if retraction and side bending is limited, you have to restore that before you progress to a sagittal plane repeated loading strategy. But I found that if someone was limited with this and they couldn't tolerate that retraction and side bending or just pure retraction or retraction and overpressure, many times what will actually modulate that and improve the ability to load the ipsilateral side is if you retract and isometrically side bend or resist side bending to the involved side, and that will usually restore retraction, and then they can overpressure and resist to the right, or overpressure, resist to the right, and actively resist and possibly do agonist reversals. But the simplest thing I found for a very irritable patient that meets those clinical practice patterns of loss of ability to load the upper quarter in or to the involved side, you keep on retracting and resisting, retract and resist to that side, and eventually that should restore pain-free or threat-free cervical retraction, and they can overpressure and possibly overpressure and range load to the involved side. So that's my clinical pearl. I would say don't force them into doing the yellow light. I find that, again, they don't really respond, and it's almost like a wasted visit if you tell them to go away for a couple days and symptoms are not really changed. I think it's because the peripheralization, they possibly don't load enough, they don't dose high enough, or potentially the nervous system is not necessarily convinced that this is a safe activity. So I hope that clinical pearl helps, and I hope that answers your questions about yellow lights and peripheralization. Thanks for submitting, Doug. Make sure you guys subscribe to Modern Manual Therapy via email. Check us out on Facebook, Instagram, and YouTube, and you have a great day.